Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about the anatomy of the biliary system. So let's begin by looking at this image, which nicely summarizes the anatomy of the biliary system. You'll see the right and left hepatic ducts coming together to form the common hepatic duct. And from the gallbladder, we also see the cystic duct, which joins the common hepatic duct to form the common bile duct. This eventually drains into the duodenum at the ampulla obvata, often alongside the pancreatic duct. It's important to appreciate this layout because even slight deviations from this standard anatomy can give big clinical consequences, especially during surgery. Many people live their whole lives without knowing they have a biliary variant, but if surgery is needed, like a gallbladder removal or liver transplant, those hidden differences can make or break the operation. That's why understanding and identifying these variants is so critical. Now, this very first variant, low insertion of the cystic duct, is a classic and quite dangerous variant if not recognized. The cystic duct normally joins a bit higher, but in this case, it inserts lower near the duodenum. During a gallbladder removal, if the surgeon doesn't really spot this, they could mistake the common bile duct for the cystic duct and accidentally tie it off. That can cause bile leaks, strictures, or even liver damage. So this image shows the common biliary variant in a 45-year-old woman with cholelithiasis, and it's a projective MR cholangiogram which shows medial and low insertion of the cystic duct. So if we follow this, the gallbladder, so if we follow the cystic duct, it goes all the way to insert very low here. This is the common hepatic duct. Ideally, the cystic duct should have joined somewhere up here, but then it went all the way down, and instead of joining it laterally, it inserts medially here, as shown by the arrow. Very low insertion of the cystic duct. Like I said earlier, if the surgeon doesn't recognize that the cystic duct goes all the way down here, in trying to tie it off, he may end up tying off the common hepatic duct or the common bile duct, and that may have dire consequences. Now for the next variant, that's aberrant right posterior duct. We need to remember the anatomy of the normal right posterior duct. So let me just quickly send us back to the normal anatomical image that we saw from the start. So if you notice, the right posterior hepatic duct supplies the posterior segments, that's segment 7 and segment 6, and then this anterior duct supplies the segments 8 and 5, which are the anterior segments. And looking at the orientation of the right posterior hepatic duct, it inserts on the medial surface of the right hepatic duct, right? So this is the normal configuration that we should be looking at. So let's go back to our variant anatomy, the aberrant right posterior duct. So here the right posterior duct decides to go rogue. It drains directly into the common hepatic duct, or it may even drain into the cystic duct instead of joining the right hepatic duct. This is mostly a concern in people donating their right liver lobe, since both of the ducts have to be separately reconnected in the recipient. When you miss one, you've got a biliary complication on your hands. So in this image of a 45-year-old woman with symptoms of extrahepatic cholestasis, this MR cholangiogram shows, besides the stone in the common bile duct, we also see drainage of the right posterior hepatic duct. Remember, ideally it should drain into the medial part of the right hepatic duct. However, this time it goes all the way to drain to the left hepatic duct before joining the right hepatic duct. So this is an aberrant insertion. Sometimes it may insert anywhere. It may go and insert in the common hepatic duct or somewhere else. Just very aberrant. Now in this variant, that's the long common channel or pancreatico-biliary maljunction. The bile and pancreatic ducts form a long common channel before they reach the duodenum, usually over 15 millimeters in length. Some literature also use 6 millimeters as their cutoff, And why does this matter? This long channel allows enzymes to flow backwards, so you can have reflux, and then pancreatic juice can then reflux into the bile ducts, and this can cause chronic irritation, strictures, cysts, and this chronic irritation can even lead to cancer over time. So this ERCP of a patient with pancreatico-biliary maljunction without pancreatic dilatation, we can see that the common bile duct and the pancreatic duct join, and then we have a long segment of this confluent. We have a long confluent segment before it empties into the duodenum. Usually these two empty directly at the ampulla of Vater. Now we can see that the two of them have joined a little early. And most of the time, the sphincter of OD is just at where the junction is, and the sphincter of OD is usually around where the duodenum is. But this time, we have this insertion or this conjunction occurring way before it gets to the wall of the duodenum, and we have this long segment more than 6 millimeters in length. It is a variant. Now, to summarize, the key message is that we should just know our anatomy, especially the variants. Unfortunately, I couldn't touch on all the variants in this short video. Modern imaging tools like MRCP make it easier to spot these variants, and intraoperative cholangiography during surgery can provide real-time confirmation during surgeries. And so taking the time to look can prevent lifelong complications for patients. The next thing we'll talk about are gallstones and cholecystitis. Thank you very much for your attention. I do hope you found some value from this. If you did, give it a like, give it a share, and subscribe if you have not subscribed yet. I will see you guys in the next one.